Warning, this video graphically displays the off-label use of air in cataract surgery. Aerolon, Aircoat, and Aerovisc are fictitious trade names and do not represent either legitimate trademarks nor purchasable products. An air bubble, an overlooked viscosurgical device. Steve Dewey, Colorado Springs, Colorado. Air, well, bubbles, are quite useful in helping position things inside the eye, especially in corneal surgery. But for cataract surgery, bubbles usually are annoying. They obscure details, get stuck in viscoelastics. But on the bright side, if we're paying attention, we can actually use a freshly operated patient as a level. All right, hold still. Nope, nope. Look to the right. Okay, no, left, left, nope. Okay, hold your eye steady here. Never mind. She's not going to hold still for us. In all seriousness, air has some very useful qualities. Specifically, a bubble's surface tension can create a pressure effect. Viscosurgical devices and air just don't mix. Air can displace or move structures in a manner similar to a viscoelastic, and air is incredibly easy to remove as long as the posterior capsule and zonules are intact. It's also not intended to be retained. So the implant's in, we're irrigating out the viscoelastic, pretty much thinking about going home at this point when just a hair sloppy. Touched the anterior chamber angle with the tip of the cannula and found this eye has an aorta. Well, before we panic, we want to break out our vial of Aerolon, the air viscoelastic of choice. We want to displace the entire contents of the anterior chamber so that the surface tension of the bubble, the pressure, is placed against the chamber angle directly against the bleeding site. Typically, one application of Aerolon is going to stop the bleeding. However, in this case, it didn't. So all we're going to do is repeat the bubble. Quite honestly, I would rather deal with 2 extra minutes on the operating table than have to put up with how we are going to watch a hyphema resolve post-operatively. As long as the vessels are non-pathologic, so in other words, as long as these are normal anterior chamber vessels, be it in the iris or in the chamber angle, the bleeding will stop, and this is true whether patients are on anticoagulants or not. So we've had this occur in patients on Coumadin, on warfarin, Lovenox, heparin, Plavix, aspirin, ginkgo, you name it, and it is very effective at stopping the bleeding, and certainly the time spent here is far better than clinically having to deal with the hyphema postoperatively. I will let you in on a little secret. I obtained this video directly from the manufacturing facility. I don't remember if this was Aerolon or Aerocoat, but I was surprised to see it manufactured in such a simple fashion. Doctor, the INA handpiece did not make it to the autoclave. I've dropped it on the floor. It's going to be 15 minutes till it's ready. And that's if we've got short cycle flash sterilization available. Boy, we've already taken out the cortex with J cannula irrigation. How are we going to confirm that the viscoelastic is entirely out of the eye? Well, first we're going to irrigate out from underneath the IOL. We're going to irrigate the anterior surface. And as we irrigate the chamber angle, we can really see the admixture of viscoelastic and BSS clearly visualized in the red reflex. Well, to confirm that I've removed the viscoelastic from the anterior chamber, we're going to put in Aerovisc. Aerovisc, the viscoelastic of choice. The nice thing about displacing this mixture out of the eye is that the viscoelastic cannot hide in the air. Now, pretty reasonable to expect that as I irrigate more and more, I'm going to get this viscoelastic out, but how do you really confirm it? Well, we're going to put an air bubble in again, a little more Aerovisc. And this time we're going to try to distend it all the way till the anterior chamber is relatively full. Now you can see the bubble almost conforms completely to the anterior chamber. Well, we're going to go back in and irrigate those specific areas out and really get the idea that there isn't any viscoelastic remaining. I use this virtually every time in a patient with ocular hypertension, with glaucoma. Really, I find that it does cut down on my pressure spikes, but I've never done a randomized study to identify whether this is true or not. And again, even without the automated INA handpiece, the air bubble is very easy to remove from the anterior chamber just by simple aspiration. Well, here we are. We're almost done with this surgical case. We've just got a little cortex left, and I really can't even get the INA handpiece, the INA tip, back into the eye just to get to those 2 little bits of cortex. Well, this lady was a little bit offended for some reason when I asked her about whether she was on medications for her prostate. Not really sure why, but actually this lady did predate our knowledge that alpha-adrenergic blockers can cause the IFAS syndrome. Well, what can we do? We can try to deepen the anterior chamber. Maybe, I don't know. Why don't we use, in this case, air coat? Air coat, the viscoelastic of choice. So as we distend the anterior chamber, we're going to leave this bubble for 60 seconds. I don't know what's magic about 60 seconds, but if you leave a bubble in an eye for 60 seconds, it really tends to get the job done. Now here's some dispersive viscoelastic. We're going to put it in the subincisional space. Then we're going to go through the primary incision with the cohesive viscoelastic and distend the posterior capsule so we can put the implant in place. Now, really not trying to overfill, but we can see there's a lot of viscoelastic coming back out, so we still have a lot of posterior pressure. A lot of tendency for this iris to prolapse. One little bit more dispersive viscoelastic under the incision just to tamponade the cohesive. We put the tip of the injector in, rotate it appropriately so we don't incarcerate the iris or catch it as we inject the IOL. And the IOL goes into the capsular bag, not in one step, but very good. And now we can actually manipulate the Lester hook, put the lens in the bag without any difficulty. And this is really going to be the test. I've got to get the viscoelastic and the cortex out. So here we have the automated INA handpiece, and the tip goes in this time. The iris lets it go right by. We're going to get out the inferior cortical remnants first, then the superior cortical remnants. And again, the air bubble has been very useful in this case to deepen the anterior chamber and allow us to work around this floppy iris. And some last pearls on the usage of air. Something about 60 seconds seems to work. When I inject it, I put it through the side port, and if I don't get a complete fill, I try to put the tip of the cannula in the fluid and try to create a second bubble. The two will merge. Bubbles can be placed behind the iris as long as you've already got one in front of the iris to keep it there. And last but not least, when you're trying to confirm viscoelastic removal, where the bubble isn't, that's where the residual viscoelastic is. Well, air is the one thing on the operating room table that we really can't live without. And of course, I just really like this shark video. But I have held my breath long enough. I am going to have to surface sometime and get some more bubbles. So air, it has specific properties that make it a useful agent in cataract surgery. It can stop a hyphema. It can remove and confirm removal of viscosurgical devices. It can help reposit an iris. That's not intended to be retained postoperatively. It is, of course, very simple to use, very easy to obtain. And again, it's very cheap unless you go for one of the name brands. And that's all. Thanks for watching.